Thank you, Missy. Good morning, everyone. On day 2, I get to come back and talk to you because we now have a neonatal presentation for you all from Dr. Susan Hwang. And I see on her screen, her name is Sunah Hwang, but I'll introduce her as Susan. She's a neonatologist, a health services researcher, and a perinatal quality improvement expert at Children's Hospital of Colorado and the University of Colorado School of Medicine. She leads the Colorado Hospital Substance Exposed Newborn QI Collaborative, which is nicknamed Chosen QIC, Chosen Quick, and the data-driven engagement of families to improve the NICU experience, which is called Define Quick. She previously led the Massachusetts Hospital Safe Infant Sleep Quality Improvement Collaborative. She received her medical degree from SUNY Downstate, her MPH from the Harvard School of Public Health, and a PhD from the University of Colorado Graduate School. She completed her pediatric residency and chief residency at New York University and her neonatal fellowship at Boston Children's. Dr. Hwang is an NIH-funded investigator whose research interest is in the transition of high-risk infants from hospital to home, with particular focus on safe sleep practices to reduce sudden unexpected infant death. Please welcome Dr. Hwang to give her talk on the transition from hospital to home for high-risk infants.
Thank you so much for that warm introduction. I am going to share my screen and would appreciate a thumbs up if all looks good from your end.
Good.
Excellent. Well, it's really a pleasure to join you, albeit remotely, from Colorado. And today's topic is certainly one that is near and dear to my heart, and a focus that I've spent more than a decade on. I have no conflicts of interest. So over the next 45 minutes, our learning objectives are to describe discharge readiness and preparation for high-risk infants and their families from NICU to home, and identify barriers and facilitators to family engagement during NICU hospitalization. This first portion of my talk that's focused on discharge readiness and preparation comes from Dr. Vincent Smith, shown here on the right. Dr. Smith is the chief of neonatology at Boston Medical Center and professor of pediatrics at Boston University School of Medicine. And Vincent has led the work within the American Academy of Pediatrics, as well as in the National Perinatal Association, in developing guidelines related to discharge readiness. So discharge readiness is defined as the desired outcome, how we want parents to be at around the time of discharge to take their NICU infant home. Discharge preparation is the process by which families can achieve that desired outcome. Discharge readiness is typically defined as the attainment of technical skills and knowledge by the caregiver, parental emotional comfort with care of a high-risk infant, and then demonstrated confidence with infant care. Discharge preparation is the process of facilitating discharge readiness for families to successfully make this transition from NICU to home. The American Academy of Pediatrics has very clear guidelines, and this policy statement from the Committee on Fetus and Newborns has provided guidance to NICUs for many, many years. And this particular policy statement is focused on 4 categories of high-risk infants: the preterm infant, the infant with special healthcare needs or dependence on technology, the infant at risk because of family issues, and the infant with anticipated early death. And I would say that for our preterm infant population, it really is a confluence of these 4 categories that we often see in the NICU. Per the AAP guidelines, transition should occur when the infant has achieved the following: physiologic maturity, coordinating breathing and oral feeds, ingesting adequate volumes and demonstrated weight gain, and can maintain a normal body temperature. And so for those of you that are in neonatal practice, this is very much what we tell families. As soon as oftentimes we do that prenatal consult, families ask, well, what are the criteria for discharge home? And we say that they can be in an open crib, they can eat everything by mouth and not sacrifice their breathing ability. and then gaining weight. Now, while the AAP focuses more on the medical criteria for discharge home, shown here are a new set of guidelines that was just released from the National Perinatal Association that's focused on, I would say, more on the preterm population in the NICU setting, in addition to really providing adequate support for families. And so this was just published in the Journal of Perinatology. In addition, if you go to the website listed there, there are a whole array of resources that will be very useful to you for your clinical practice. And so the core value that is guiding these set of guidelines are that it is absolutely essential that we have to support the family to assure they have the skills, knowledge, and confidence that they'll need to take their infant home. The contents of these set of guidelines are divided into 4 areas: basic information, providing anticipatory guidance, doing a family and home assessment, and ensuring that there's transition and coordination of care. And so if you go to this website, it is an interactive platform that, again, has a whole array of materials that I think will be really, really useful for your clinical practice, and also providing education for your families. Now, with respect to the first bucket of basic information, we need to provide educational goals as well as a timeline to our families. And this should not be unidirectional, established by the NICU providers, but really engages with families around what are the goals that they would like to attain to feel confident in taking their baby home, and what is their timeline. Their timeline may not be the timeline that we typically may establish in the NICU, and we have to be really cognizant of that. Ideally, NICU should have a curriculum of skills and knowledge that we would like families to have before discharge. There should be very protocolized educational strategies so that this the discharge preparation is not left up to individual providers that happen to be providing care for that infant on a given day. Now, supplementary materials to augment education can range from being printed materials to digital to videos, etc. But really, I think we have to be very mindful also of the health literacy level of our families, as well as what are the best ways that a certain family may learn versus others. Families should demonstrate infant care skills far in advance of discharge. We know that car seats and car beds vary for our preterm population, particularly if they're below a certain weight. And so we have to ensure that they have the adequate item that is selected. And then while the NICU discharge program focuses on a whole array of infant care practices, safe sleep is one that gains particular focus, and appropriately so. We know that sleep-associated infant death is far more prevalent in the preterm population than the full-term population, and that preterm infants have anywhere from 2 to 4 times the risk of sleep-associated death than full-term cohorts. We also need to educate families on what's typical versus atypical behavior for the preterm population. And so this is getting at, family awareness of what developmentally, but also neurodevelopmentally is appropriate for the preterm group. Now, moving towards family and home assessment, we know that we are not discharging infants to the perfect ideal environment that we imagine from our own biases would best foster the growth and development of that infant. So we need to meet families where they're at. And so a comprehensive family assessment that includes caregiver mental health as well as infant mental health should be assessed. And by infant mental health, for those of you not in neonatal practice, this may seem like an odd term. What we're really getting at is dyadic interaction and health. What is the interaction between the primary caregiver, that oftentimes is the mother or the birthing individual, and that infant? What are the cues that are being exchanged bilaterally, and how can we best foster that dyadic development? And lastly, and importantly, we need to think about how we best transfer and coordinate the care of this medically complex infant. For weeks to months, this infant has been cared for in somewhat of a cocoon in a very controlled setting in the NICU. And now we are transitioning this family to the home setting where there are going to be a whole array of providers and other individuals that will be involved with this infant's care. And so in addition to the primary caregivers who serve as the medical home of the infant, we need to think about who are the other subspecialists that are involved in the care of this infant. It may be ophthalmology for retinopathy of prematurity, it may be pulmonary for chronic lung disease, cardiology for pulmonary hypertension, and a whole host of subspecialists that likely are involved. If your unit or hospital is fortunate enough to have a care coordinator or a discharge coordinator or what we call a navigator, they're really a critical component. They're a wonderful bridge from hospital to home that really walks with the family through that NICU stay and ensures that even post-discharge, they have the right referrals and supports in place. There should certainly be greater integration of the NICU with other community organizations that may exist. You know, this is sort of an early stage, I would say, of neonatal transition care, but a really important one. There is a growing number of community organizations that exist, and I would say probably more so in more urban settings than rural, that have been created to support families of high-risk infants. Routine home nursing visits may be available depending on where this family lives. Partnerships with the Nurse Family Partnership or other home visiting services that exist in certain states may be appropriate for these families. Early intervention is a big one. For those of you unfamiliar with EI, early intervention is a federally mandated, state-administered developmental support program for high-risk infants. Services can be provided from shortly after birth all the way through age 3. Now, states have varying eligibility criteria for who automatically qualifies, but every infant, if a referral is made, must be assessed. So by that, I mean, even if there may not be clear eligibility criteria that are present, every infant, if there is a concern voiced by a medical provider, a social worker, a parent, really anyone about the particular infant, EI has to come in and do an initial assessment. I would say many of our preterm infants, just by their gestational age and birth weight, are likely eligible, but you may have many late preterm infants, those born between 34 and 36 weeks, or you may have substance exposed newborns that may not automatically qualify, but certainly should get an initial evaluation. Now, discharge summary has a whole line on its own because the way that the hospitalization facts and details are transferred to the outpatient provider can be quite variable. So I think it's really important to first understand what is your workflow around discharge summary creation and then transfer of that information to the outpatient provider, but also have a conversation with outpatient providers to understand what facts during the NICU hospitalization or what about the hospital course would be most appropriate for the outpatient providers to know about. So it feels like there are guidelines in place, almost like a checklist that provides a roadmap for how we can best transition families from hospital to home. But we know that checklists don't tell that whole story, that it really is just the tip of the iceberg when we think about family preparation for home, that there is a lot below that underneath the ocean that's not visible, that absolutely will influence the health and well-being of the infant and the family. And so what we're really getting at is a broader issue of patient and family engagement. How do we involve families equitably during NICU hospitalization so that they are best prepared to take their baby home? And so while there are many definitions of family engagement, I really appreciate this one from AHRQ that states that family engagement are a set of behaviors by patients, family members, and health professionals, and a set of organizational policies and procedures that foster both the inclusion of patients and family members as active members of the healthcare team and collaborative partners with providers and provider organizations. Critical elements of this definition is that there are behaviors that occur at individual levels, but also structural policies and procedures that seek to really be inclusive and to consider families as collaborative partners. Measurement is a problem. How would we define parental engagement in terms of a process or outcome measure? What are we really measuring? Is it the time that the family spends in the NICU? Is it their presence on medical rounds, their understanding of the infant's medical condition, or demonstrated comfort and proficiency with the infant care? And by caregiver, are we talking about just mom and dad? What about grandparents, other caregivers? So measurement continues to be an issue when we talk about parental engagement. That being said, there are several frameworks that can guide measurements. This is one that I really like, again, from AHRQ. And what this posits is that on the left side, there are an array of individual characteristics, both at the patient and family level, as well as the healthcare professional level, that influence organizational as well as individual behaviors here in the middle. And that in this kind of interaction, we know that there is broader context, that what is the organizational context of the hospital and perhaps broader community that interacts with both the individual characteristics as well as organizational factors. And what are some hospital-based interventions, strategies that we can think about that, again, act upon this relationship? And importantly, what are the anticipated outcomes? You know, our hope is that increased family engagement in this conceptual framework would lead to improved communication, improved provider-patient partnerships, improved quality of care and patient safety, improved patient experiences of care, more efficient use of resources, improved provider satisfaction, and then improved patient outcomes and health and well-being. Now, family engagement or optimal family engagement is the goal to ensure discharge preparation is optimized to establish discharge readiness. Well, what are some barriers to family engagement in the NICU? There are several. And the first one is a structural or policy issue, legislative issue, certainly an equity issue, and that's maternity leave or lack thereof in the United States. The US is one of only 7 countries without national paid maternity leave. We're the only developed country that does not have a paid leave program. For families that do not have the financial resources to take leave, this is absolutely a huge barrier for their ability to be at the infant's bedside. And yet, there is a wide body of literature that family leave, in fact, is really important for child health. This is one of many studies. This is quite a large one. And this was annual aggregate data that were analyzed for 16 European nations between 1969 and 1994. Here, these 16 countries offered a minimum of 10 weeks of paid leave. 6 nations offered more than 6 months of paid leave. And the full pay weeks ranged from 9 weeks in Greece to 58 weeks in Sweden. What this analysis demonstrated was that for every 10-week extension in paid leave, there was a predicted decrease in infant mortality ranging from 1 to 2.9%. Post-neonatal deaths specifically predicted a decrease anywhere from 3.7 to 4.5%. Moving beyond the infant period, even child fatalities were predicted to decline by 3.3 to 3.5%. They calculated that the cost per life saved with a paid leave in place would be between $2 and $3.8 million. Now, health economists, and I am certainly not one, typically place a dollar amount in the value of life in the range of $3 to $7 million. Therefore, parental leave is clearly cost effective in its benefits. Here in the US, what we have is what we have, and it's not much. The Family and Medical Leave Act of 1993 established 12 weeks of unpaid leave per year for mothers of newborns or newly adopted children. And there were still restrictions to that, that it was restricted to employees in a firm of 50 or more employees, that these folks have to be employed with the same business for at least 12 months, accumulated at least 1,250 hours over 12 months. Now, fortunately, states have taken upon themselves to enact state-level maternity leave policies that are far more generous than this federal legislation. And so some states like California, New Jersey, Rhode Island, and in New York have enacted state legislation to better support families. Here in Colorado, we have the Family Medical Leave Insurance Program. And so it's a social insurance program that offers 12 weeks of partially paid leave to care for a worker to care for themselves or a loved one. And so this would include an individual who recently gave birth. Now, this is an insurance program in that prior to this delivery or whatever event has occurred, that workers are paying into it a fraction of their salary. So maternity leave or lack thereof is certainly a barrier. Family residence from the NICU, the distance that they live from the NICU, is also a barrier. This is a study that was conducted a fair time ago, published back in 2007, but investigators sought to understand how the distance from home influenced maternal and paternal visitation. And they found that decreasing visiting frequency with increased distance from hospital to home. And so here they stratified distance by less than or greater than 30 kilometers from the hospital. And here you see visiting frequency was defined as days per week, and found significant differences by distance from home, both for mothers and fathers. So here in Colorado, we serve a very, very wide catchment area. If you're not familiar with the Rocky Mountain area, states like, for instance, like Wyoming, which is just north of us, actually don't have a NICU because there are not enough births in that state to establish a NICU. And so here in Colorado and at Children's Hospital Colorado specifically, we serve a very wide region. And so our group wanted to understand what the transport patterns looked like for this population of states and babies that we serve, and specifically to understand what are the predictors or factors associated with back transport, meaning that baby has come to our level 4 intensive care unit to receive acute care, but what is the likelihood? What are the factors that are then associated with transferring that baby closer to home to a lower level of care after acute care has been received? And so we want to understand, in addition, that for infants that were medically, quote unquote, eligible to be closer to home, but remained with us, for how long were they in our level 4 NICU? Pretty far from home. And so the data source for this study comes from the Children's Hospital Neonatal Database. It's a consortium, and it's data that's prospectively collected from 29 children's hospitals throughout the US. For this particular analysis, we used our local data here at Children's Hospital Colorado. We are a level 4 unit. More than 50% of our infants are outborn. We have about 400 annual admissions a year. And Children's Hospital has been participating in this database since 2010. And so shown here for our cohort is the catchment area. And so as I highlighted, we serve a really wide swath of the Rocky Mountain area, as well as our Plains area to the east. And so our infants come from the states, I would say primarily Colorado and Wyoming, but we certainly have a fair number from Montana, Idaho, and the Dakotas. What was interesting from our study is that among all the infants that were medically eligible to be back transported, defined as they're on full NG feeds and low flow nasal cannula, so criteria that conditions or medical equipment that can be handled by any level 2 NICU closer to home, of those medically eligible infants, only 26% were back transported closer to home. In our adjusted analysis, we found that the predictors of back transport were that Infants that were publicly insured were far less likely to be back transported to home. And for infants that lived further from home, they were more likely to be back transported. So here we certainly see this disparity or inequity around insurance in particular being demonstrated. In addition, for those infants that were not back transported, which was nearly 3/4 of them, their length of stay in our NICU was nearly a month, 28.5 days. So a month before discharge is a critical time period that families can certainly be more actively engaged and prepared to take this infant home. And yet many of our families were far from home, even when their babies were quite stable. So we've talked about maternity leave policies, we've talked about distance. Now we're going to transition to language, primary parental language, and how that may impact family engagement in the NICU. This was a prospective cohort study that was conducted by Dr. Mauricio Palau, who's now a neonatologist at Denver Health Medical Center, one of our safety net hospitals. And he conducted this study while he was a neonatology fellow in our program. He interviewed English-speaking and Spanish-speaking families in 2 hospitals on our Anschutz Medical Campus, at our delivery hospital, as well as our children's hospital. And what he demonstrated was that Spanish-speaking parents were far less likely to correctly identify the reason that their infant was admitted to the NICU compared to English-speaking families. And this was not an expectation that families give the exact medical diagnosis that we bill for, but really in layman's terms, how that family would describe why that infant was in the NICU. Dr. Palau found that there were educational differences between Spanish-speaking and English-speaking families, and therefore adjusted for that. And even with that, found that Spanish-speaking parents were far less likely to correctly identify their infant's admission diagnosis. Moreover, he demonstrated that for Spanish-speaking families, when asked how they were most frequently communicated with, families reported that for both nurses and physicians, the majority of the time they were communicated with in English. And so language absolutely impacts family experience in the NICU. This was another study that we conducted in 4 NICUs in Colorado to better understand what are some of the factors that are associated with maternal engagement in the NICU for our local population. So we enrolled about 211 maternal infant dyads from 4 NICUs that are in Colorado, mainly in a metro area. And we analyzed data for about 180 maternal infant dyads. And what we found were that there were a whole array of social factors that are associated with maternal time in the NICU. Now, this is not going to be a surprise to anyone, right? This is what we live and what we know, but I would say this is one of the first studies that explicitly stated it in a published paper. And what we found was that families who had a higher household income, who lived closer to the NICU, and who did not have other children were far more likely to spend time in the NICU than the comparison groups. Not rocket science, but demonstrates that social determinants of health absolutely influence families' ability to visit their infants. The next barrier is diversity or lack thereof in our workforce, that there is a disparity in the socio-demographic, the racial profile of our healthcare provider group compared to the population that we serve in the NICU. And we know that disparities in parent satisfaction, parental engagement, and a whole host of other outcomes do vary by race, level of education, income, gender, and disability. And I show this picture here really because in 2021, it was the first time that an Asian American puppet was introduced to Sesame Street. 2021, that was quite surprising to me. And I wonder for myself what my experience, perception of my life really as a child in a certain educational system, what I watched in the media, could have felt different had there been more Asian representation in what I was watching, even as a child. And so, as I mentioned, we know that there are disparities in family experience in the healthcare system by race ethnicity. This was a study of surveying parents of children with special healthcare needs. Nearly 40,000 parents were surveyed from 2000 to 2002. And authors demonstrated that Black and Hispanic families were far more likely to be dissatisfied with the care that their child received compared to white families. What was very interesting also in this study is that these authors then tried to do a deeper dive in what could potentially be driving this greater satisfaction amongst Hispanic and Black families. And what they found is that for Hispanic families, that Hispanic-white disparity in dissatisfaction disappeared after they adjusted for interview language, meaning that primary language was a mediator in that relationship between dissatisfaction and ethnicity. For Black families, that Black-white disparity and dissatisfaction went away only after adjustment for family-centered care factors were accounted for, specifically inadequate time spent with the provider, the amount of information given by providers to families, provider listening skills, and partnership with families. And so these three components these authors highlight were really mediating that relationship between that Black-white disparity or dissatisfaction among Black families and the outcome of dissatisfaction with care. And so these are important because there's areas of potential interventions that can be developed to address specifically these factors. So I've highlighted some barriers to family engagement that clearly will influence the success of transitioning a high-risk infant and their family from hospital to home. Now, I'd like to offer some possible solutions, and solutions is a question mark here because I want to highlight that context matters, right? So I'm going to share with you a number of possible solutions, but really how these are implemented in local settings, say in Georgia or others. You know, adaptation is going to be necessary, and its success can only be defined by, you know, how you all locally define success. So hence the question mark. So I want to start with some efforts that are taking place here in Colorado. The first is a quality improvement collaborative that's occurring in NICUs throughout our state called Define Colorado. And that stands for Data-Driven Engagement of Families to Improve the NICU Experience. Shown here is our key driver diagram. It is very busy. I don't expect you to understand or even read all of these different boxes, but I want to highlight our primary aims. And so we state that by a certain time period, December 2023, I think is still an ambitious goal, but that hospitals will improve family engagement in NICUs by one, improving parental engagement parental report of engagement, in infant health and development during NICU hospitalization by 20%, and two, reduce disparities in parental report of engagement by race, ethnicity, primary language, and distance from the hospital by 20%. So two things that I want to highlight in how we came up with our aims. The first is that our aim is not based on provider report, electronic medical record, some clinical outcome. It's really parental report. So key to this is that this is a family-centered effort, and we want our primary aim, outcomes, and even some of our process measures to be coming directly from the parent perspective. The second is that we have embedded equity or reduction of disparities into this effort from the outset. That really, unless we're going to reduce disparities, this effort will not be successful. The four primary drivers that we have identified related to family engagement are communication between NICU staff and families, identifying and providing social and financial supports for families, fostering family engagement and hands-on NICU care, and then family participation in discharge planning. We do have a centralized data system, and while we recognize that hospitals that put some of these interventions in place, are affecting the whole population of NICU families that they serve, we know that, data abstraction for all of those families served may be too burdensome. We are limiting our efforts to infants admitted to level 2, 3, or 4 NICUs who have at least 14 days of NICU hospitalization. That being said, some of our smaller units, especially our level 2s, have stated to us that, some of their infants don't stay that long. If they're a 35-weeker, they may stay a week. And so these inclusion criteria have certainly been altered and adapted over time. There are no restrictions on parents or caregiver presence during hospital stay due to significant social issues. And then for large volume centers, we recognize that, again, entering data for all of the infants that are coming through is too burdensome. And so we have certain kind of ways to ease that data burden. One is that they would select the first 15 admissions who may meet the criteria for database inclusion. As I mentioned, this is all through virtual, online REDCap data system that's housed within our university. We do have to go through some, legal hurdles for data sharing to occur even in a de-identified fashion. And our data source really is patient level EMR that's fairly limited, and the parent surveys, which comprise the majority. And so for the parent surveys, this is the frequency of administration. Shortly after NICU admission, a family is approached about our defined effort. They share their email or phone number, and we send them that survey through those routes. About 2 to 4 weeks into the admission, the first parent survey is sent. Around the time of discharge, the second survey is sent, and then 1 month post-discharge, we have a third survey. Now, I mentioned earlier that there is no validated tool for assessing family engagement. And so we selected these 3 questions to capture that. And so the first asked, since your infant was admitted to the hospital, how much effort has been made to help you understand his or her health issues? It's a scale ranging from no effort to every effort. The second question, have you had enough input or say in your infant's care? No to yes, definitely. And then since your infant was admitted to the hospital, how often have you felt like a parent? Again, a scale ranging from I always feel like a parent to I do not feel like my baby's parent at all. I'm going to share with you a few of the intervention approaches that have been developed by some of our participating hospitals as part of this defined effort. The first one is called DPOC, discontinuation of pulse oximetry checks. This comes from Dr. Meg Kirkley, who's a neonatologist at Denver Health, our safety net hospital. And she recognized that among medically stable infants who are fairly close to going home, that both families at the bedside as well as their providers were focused more on the pulse oximeter than the baby, especially around feeding. That beeping of that pulse oximeter was more of a cue than the direct infant cues that were being observed by those at the bedside. And so she sought to increase the use of discontinuous pulse ox checks or discontinuation of continuous pulse ox checks, so that instead of having these infants attached to a pulse ox, continuously 24/7, that they would only be spot checks, twice per shift. And really, this would be for medically eligible families or babies, so that the family in particular is really focusing on that baby, particularly during feeds. The second intervention was developed by Dr. Stephanie Bork and Elizabeth Shireholt, who's a neonatal nurse practitioner in our children's hospital NICU, and it really sought to standardize discharge preparation to achieve discharge readiness. And, prior to this, as may be the case in many NICUs, even in Georgia, is that, we have this list that families have to get through, knowledge that has to be imparted, but really the timeline is quite variable. And the way that that information is shared with families also really variable, and oftentimes at the discretion of the nurse that has that baby for that given day. And so this effort sought to introduce this patient and family education checklist to parents or caregivers as early as sort of reasonably possible. And here it's once the infant has achieved 32 weeks corrected gestational age, or when the infant is off positive pressure ventilation, defined as less than 2 liters of hypoglycemia, and on full NG feeds. Now, the NICU here in Colorado that is really leading the field is St. Joe's Hospital, St. Joseph's Hospital. This is a level 3 NICU that's here in the Denver metro area. And they're really the only ones that have adopted family integrated care. So family integrated care is an evidence-based approach to family engagement that's been well studied in a large randomized multi-site trial that demonstrated higher rates of breastfeeding at discharge, shorter length of stay, as well as decreased parental stress and anxiety. And so there's a growing body of literature that family integrated care is in fact effective. And I think it's still taking a bit of time for NICUs to adopt it because it is quite a comprehensive program. So St. Joseph's has put it into place, and their goal is that in partnership with families, that there's a consistent and nurturing environment where parents feel engaged, enabled, educated, and empowered to be the primary caregivers of their baby. So in their program, parents do a whole host of things. They're involved in feedings, even hanging feedings on the pump, diaper changes, obtaining vital signs, giving oral medications, tracking progress. They have their own sort of diary, participating in medical rounds, as well as decision-making. One of the most remarkable things I've witnessed when in my visits to St. Joseph's is observing a family, a mother or a father, actually present on medical rounds. It is quite remarkable, and the family is incredibly engaged. Another intervention that we have embedded is a peer support program. This is one example called the Parent-to-Parent Partnership Program here at Children's Hospital. And it's really embedding those that have lived experience in ICU care, but are far removed from their experience. So there's been some time embedding those individuals into the supports of families that are experiencing ICU care at present. So these peer support partners are provided training to then be a resource for our currently hospitalized families. And so the parent partner is involved in offering psychosocial support, really around relatability, having had that common lived experience, assisting with resource navigation, and then some self-management. What are some coping strategies, empowerment strategies that families can adopt? Now, those are some approaches that we've adopted here in Colorado. I wanted to share some work that's happening in other states and highlight the work of these two investigators, Drs. Diana Montoya-Williams and Dr. Gabby Cordova-Ramos. And for those of you that are really interested in operationalizing equity-focused ideas, innovations into the units, please, please, please invite these two individuals to whatever activities you may be having going on, such as this type of forum or annual meeting. So Dr. Williams is an assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania, and Dr. Gabby Cordova-Ramos is an assistant professor of pediatrics at Boston University School of Medicine. So I'd like to start with highlighting the work of Dr. Diana Montoya-Williams, and she focuses on immigration, particularly in the Hispanic population, and how that might influence perinatal health outcomes. And so she states that immigration is a social determinant of health. We know that punitive immigration policies increase the threat of adverse legal consequences or deportation for immigrants. And we know that these punitive immigration policies have been on the rise since the 1970s. Two examples, the Arizona 1070 bill, as well as the federal Muslim travel ban of 2017, have been associated with increased rates of low birth weight and preterm birth in those populations impacted by these policies, decreased use of public assistance programs, as well as decreased use of preventative healthcare visits in these communities. And so this is what we call the chilling effect, that the immigrants' voluntary withdrawal from or lack of engagement with health and social benefits for themselves or family members despite being eligible to receive these services. Some possible reasons are that families might be confused about eligibility. They perceive risks to family members' immigration status and chances of citizenship. And they have legitimate fears of deportation and family separation if they were to engage with these services. And so Dr. Montoya Williams highlights that there's minimal literature that asks immigrant Latina birth parents what would make them feel safer to engage with the healthcare system right now. And the goal of her project is to develop community-informed changes to the healthcare system that confer structural resilience to the chilling effect among Latina birth parents. And so she formed the PRIMA study, and this stands for Promoting Resilience in Immigrant Mama Study. It is a community-engaged qualitative study of Philadelphia Latina immigrant birth parents. And the goal is to create and disseminate a prenatal care chilling effect mitigation toolkit for local implementation and evaluation. And so this qualitative study has concluded, results have been published in the Health Services Research Journal just this year. But what Dr. Montoya Williams found that could be translated into clinical care changes were the following. And so here are some suggestions for meeting the unique needs of pregnant immigrant parents. One is that parents wanted direct reassurance from their medical providers that seeking prenatal care would not lead to reports made to immigrant enforcement agencies. And I would say we could then extrapolate this into NICU care, that if they were to receive some services during the NICU hospitalization, to clearly state to families that this does not lead to involvement of enforcement agencies. Participants suggested that increasing access to interpreter use would improve their experience in the healthcare setting and mitigate their stress and feelings of discrimination. They wanted more access to trusted sources of information, that in addition to healthcare providers, that they would hope that systems would partner with community centers and churches to help build community awareness and trust, and to combat ongoing misinformation about immigrant rights to healthcare. And then lastly, participants wanted a hospital administration or the clinic staff, or here I would say the NICU team, to utilize interpreters to explain the financial aspects of accessing healthcare. What is the cost to them that their infant has this prolonged hospitalization in the NICU? And so you can imagine that the results of this study can absolutely lead to an intervention toolkit to serve this particular population. I think the critical piece is, how do we think about operationalizing some of these components in our daily workflow? The second body of work developed by Dr. Gabby Cordova-Ramos comes from Boston Medical Center, which is the largest safety net hospital in New England. They serve primarily a non-English speaking and minoritized population of infants and families. And so she conducted a quality improvement effort to improve social risk screening and referral to resources in the NICU. This quality improvement effort took place from November 2020 to January 2022. And so the critical pieces of this were these four key drivers. That she recognized there was a lack of systematic social risk screening using a standardized tool. She addressed this by embedding the Thrive social determinants of health screening tool. That's a validated tool that had already been in place in the outpatient setting at Boston Medical Center. She also identified that there was a lack of standardized process to link families with resources. It's a common complaint that we see amongst providers, that we can screen, but if there are not resources available to refer families to, then what is the point? And so she wanted to improve this connection from identification of a resource need to actual resources. She also recognized that there was a lack of unit-wide approach to integrate this screening effort and referral into routine workflow, and that staff knowledge in conducting social risk screening and then referrals was also variable. And so you can see here the number of change concepts and interventions that they put into place at Boston Medical Center. So shown here is our process control chart. So in the upper figure is the percentage of families that receive standardized social risk screening amongst those that were eligible. And so when the effort first started, there was no standardized social risk screening in place, hence the 0%. And then through the series of PDSA cycles, they saw dramatic improvements in standardized social risk screening, close to 50%. Below is shown the percentage of unmet needs for which families connected with resources among all needs. And so again, really dramatic improvements in their outcome from about 20% to greater than 50% by the end of their effort. Here we see stratified by the unmet needs identified, as well as the resource information requested. So in the blue bar is the percentage of unmet needs that were identified by these different types. And then in yellow, what percentage of those families then requested information. And so what I find really interesting here, first are the type of needs that families have, and that nearly all of the families requested information, after those needs were identified. And so the need buckets were related to education, transportation, employment, food insecurity, utilities, housing, and childcare. And I'll note that there were no families through this period that refused screening. So it was very socially acceptable to families if they knew that it was happening for every family in the NICU. And critical to this piece was ensuring equity. And so Dr. Cabby Cordova-Ramos and her team also measured their outcomes by race, ethnicity, and primary language. And they found no statistically significant difference in the percentages of families screened by race, ethnicity, or language. And so in conclusion, I hope I have convinced you that parental engagement in the NICU is the foundation for discharge readiness and preparation for high-risk infants and their families. And while there are significant barriers to parental engagement, evidence-based interventions are available and should be strongly considered as part of routine neonatal intensive care. Dr. Diana Montoya-Williams is the source for the last two slides that I want to share that continues to resonate with me no matter how many times I have read these slides. She says, the home our infants are born into may not be the one we discharge them to. It's our job to understand them both. And if we begin to truly consider the health of the family at home as part of our job, then the work we do inside our NICUs and newborn nurseries will have a better chance of leading to the ultimate goal of helping our patients achieve the best version of themselves as they grow up. I have many, many people to acknowledge for this work. We work with a number of different nonprofit organizations. Of course, our Colorado Perinatal Care Quality Collaborative, GaPQC. We have a core Define leadership group. Illuminate Colorado is a nonprofit based here in Colorado that's focused on improving family well-being and reducing child maltreatment. Our section of neonatology has supported a number of these efforts, especially when they were in its very early stages. And shown on the right are my funding sources. So thank you so much for your attention, and I would be happy to take any questions.